that I've had, and I guess I've kind of viewed that as my role actually on public health reform, because fundamentally public health was grounded in local government. That's where its origins come from, and I kind of viewed it as my role to just remind everybody on the public health programme about the important role that local government has played historically, currently does, and will continue to do. And we wanted to publicly congratulate Angela. Secretly, it's nice to have one of our own taking on the first role. And I think that will be important, again, just making sure that we recognise that Public Health Scotland will sit in a whole system of which local government is an important part of that whole system. I wanted to just remind you, I guess, as we reach some of these significant milestones that John was referring to, just to take you back, and of course it goes beyond all of our working life memories, but to remind you of the past of public health in local government, say a wee bit around where we are currently, and then open the challenge to you about what we want our public health leadership to look like going forward. So starting with the past. This was the past. North and south of the border, across the entirety of the United Kingdom, cholera, typhus and smallpox were major killers in the 19th century and were the result of environmental pollution, poverty and bad housing. Advances in the medical model and advancements in the improvement in the environment and diets, what we would now today recognise as the determinants of population health, have led largely to the eradication of these major killers in the United Kingdom. So what was local government's role in the eradication of these 19th century killers? As a result of the Public Health Act of 1848, for the first time the state became the guarantor of standards of health and environmental quality and provided resources to local units of government, local government, to make the changes to achieve those standards. The second Public Health Act gave local units of government, local government, the power to ensure that houses were connected to the main sewage system, and the Act forbade the building of new houses without such connection. And local authorities had the power to supply water and to compel residents to connect their houses to water supply. In Scotland, these UK pieces of legislation were eventually laid out in the Public Health Act of 1897, and the Local Government Board was assigned the central authority for the execution of that Act here in Scotland. These were significant pieces of legislation resulting in significant social change. And why was that? The deadliness of cholera induced much of it. 50% of those who contracted the disease in 1832 died, and cholera struck all social classes. So the volume of people affected and the fact that all classes of population were affected drove that drive in terms of population health and public health, and significantly placed local government at the heart of the solutions. That passed largely, and I have to say, in doing the research for this presentation, really surprised by how much that past has shaped and continues to shape what we currently do today. So at the time, there was a struggle to understand what was the volume of the epidemic, the volume of death that was happening across the entire country. There was no knowledge of the volume. There was no record keeping of that. And in 1855, the Civil Registration of Births and Deaths legislation was introduced, what we would today recognise as our registrar function. So again, placed at the heart of local government the responsibility for recording death, the causes of the death and the prevalence. It wasn't uncommon at that time either in the cities for 12 to 16 people to be living in one room, much of what we would see in television programmes of the past. What was the solution? House building. And we continue, of course, to play a strong role in that today. Infant mortality in Scotland, when you go back in time, was 120 per 1,000 live births, and health of children was incredibly poor. What was the solution? Again, significant legislation. The Education Act of 1908 created compulsory medical inspection of school children. As I walk through all of this legislation, you'll see how it's shaping exactly the functions that we discharge today as local government. 1919, maternity and child welfare schemes were put in place. Local authorities were empowered to provide food and clothes for those children who were classed as poor or needy. We're still doing that today. And surprisingly, local authorities were responsible for vaccinations at this time. There were different opinions and views around the right approach to take in terms of addressing these public health issues. Edward Chadwick of the time believed that the causes of disease were due to toxic odours in the atmosphere and that these were the result of dirt and poor sanitation. A significant piece of public infrastructure work was done in terms of building a sewer and water infrastructure. And again, the legislation placed a duty on local authority to clean up the streets. We still do that today. Others believed that disease was spread by touch and originated in contaminated water supply. And again, the solution was to create a public water supply, which the local authority was responsible for. I remember when I started in local government, before 96, we had responsibility for water until the creation of Scottish Water. Conditions in the workplace were also identified at that time as contributing to many of the problems, and the average death age of factory workers in comparison to colliers was significant. And again, a piece of legislation introduced in the 1897 Act placed a duty on the local authority to inspect workplaces. The 1860 Act again placed duties on the local authority. Milk was being diluted by water that had already been infected, again, which was spreading disease. Duties placed on the local authority in terms of the regulation of food and water, much of what we would see within our environmental health colleagues today. Our remit was also extended to cover port authorities that fell within the local authority area, and again, our own environmental health colleagues today would inspect ships that arrive in any of our harbours across Scotland. And I think the introduction of what we would now recognise as building control, the functions that largely now sit within our planning functions, that placed a duty on the local authority in terms of regulating buildings, the drainage of sites, the structure of buildings, the ventilation, the space, the construction of waste pipes, much of what our building control colleagues continue to do today. And when you go back to the legislation, it was quite prescriptive. It prescribed certain positions that local authorities had to have within their organisational structures. We were required to appoint a medical officer. Isn't it interesting today the medical director sits within the health system, but at this time the medical officer sat within the layer of government of local government. So a medical officer of health meant a whole host of environmental issues such as water and air pollution could be addressed and remedied. And he, and of course the legislation said we wouldn't get away with that today, but the legislation does say that he, the medical officer of health, had the right to enter and inspect any property where there was a suspicion of infectious disease. And the officer would direct dead bodies to a local authority mortuary. Again, we continued to deliver the mortuary function. We were required to have sanitary inspectors, and we continue to hold much of that, and surprisingly, a veterinary surgeon. But again, you can see the origins of the requirement around the veterinary surgeon in terms of underpinning environmental health work today on food. So the surgeon was required to inspect and examine any animal, alive or undead, intended for the food of man, issued certificates. Much of what we're debating in this last few weeks is about those health certificates in relation to Brexit. So it's interesting, isn't it? Much of what we're doing today has its roots way back. And we also had the ability to employ nurses, and nurses to attend persons suffering from infectious disease if the authority wasn't providing a hospital. So at those time, of course, it was a mixed hospital model, both public and private. But the local authority had the power to provide hospital. But where it didn't have the resource, then it could employ nurses to go out and do what would we call today community nursing. So again, origins in all of us. Today, as we talk about public health reform, we talk about the specialist workforce, and sometimes we're falling into the trap of defining that as if it were the specialist workforce of NHS. as if the preserve of public health was the preserve of NHS. But I think what all of this evidence is that the preserve of public health has originated in the hands of local government. So what's our present? If that was our past, and if we've largely dealt with those causes of population health, smallpox, typhus, and so on, what's our present? Well, I don't need to tell you in a room like this about many of the issues that we are dealing with. The major killers today are, however, more the result of post-World War II affluence than they are poverty. Obesity, alcoholism, smoking have greatly increased due to high standards of living, and they have an adverse effect on health standard. They are affecting a volume of people, and they are affecting all classes of people. Not much difference then than when we go back to 18th and 19th century too, but just different causes. A number of challenges that we're dealing with are health challenge, growing volumes of obesity, children and adults, long-term multiple conditions, difference in the health life, length of life of people in deprived areas in comparison to affluent areas. Our economic challenge, again, understanding that economy, of course, is a key determinant of our population health, and we have enjoyed significant economic growth. But it's probably fair to say that some of that past growth questions around its continuation as we go forward, and what are the risks to our economic growth in a post-Brexit world. Over 2/3 of Scotland's economic activity sits within cities and within their immediate boundaries. The nature of our growth, and again, just looking at in population terms, so if you take my own hometown, 31% of Dundee's employment is in the public sector. So we think about our economy and the importance of vibrancy and the importance of a private sector as an employer for the future. We do have challenges as a country around securing that future economic growth and understanding where that growth is going to come from. In my own city of Aberdeen, we've enjoyed significant economic prosperity as a result of oil and gas in the city, and we've had huge employment as a consequence of all of that. But a real debate and discussion and work going on about how we diversify our economy to ensure that we continue to prosper as a city. An inclusive growth challenge, and I guess that what we are experiencing is that we still have significant pockets of deprivation. I just picked out this statistic. 5% of the most deprived data zones in Scotland. Glasgow contains half of them. That's significant, isn't it? Aberdeen and Perth, none. So whilst it's important to strive for our economic growth, it's important that we learn lessons. Even Aberdeen, that's had significant economic growth, that growth hasn't benefited everybody. So that model doesn't always guarantee an inclusivity and that everybody gains from that growth. So real challenges, and again, thinking about the nature of what will underpin our economy, the nature of work, the nature of skill and capability that's required in order to work in those industries of the present and the future. Lots of coverage in the media recently about our population challenge, the balance between, I guess, an ageing population is forecast to be 79% increase in the over 75 population over the next 25 years. That's not an economically active population, and at the same time, migration that we've relied on quite extensively for quite a period of time risks to all of that, particularly exacerbated by Brexit. So the challenge around having a working age population that's fit for the economy that Scotland needs for going forward, and a working population that can take care of that growing over 75 population. And environmental challenges. My 14-year-old was on the school march on Friday. I hope your kids were too. Great banners. their future is in our hands, and they're advocating, and they are not going to they're not going to go away. So real challenge, real financial issues about how we're going to adapt. But thinking about those environmental challenges, that if we don't deal with them now, then actually what are some of the health consequences of all of that? In my region, 80% of the flood risk sits in the city, but actually is that going to be a real future risk? And we spend a lot of time in our resilience partnerships planning for rain and snow. We don't really have extensive plans for planning for heat. We had a couple of really dry spells. I'm sure your parts of Scotland did too. And that requires a really different response. So if temperatures are heating, if we're not able to deal with all of that, what does that mean? Our buildings don't have air conditioning in this country. We are well suited for rain and water, for rain and snow. We're not so well set up for heating and overheating. So I want to just leave you to think about our future. If that was our past, and actually we were hugely instrumental in the shaping of public health. What we've seen in a duration of 100 years is the splitting up of much of that delivery activity and spread across a plethora of bodies that now sit here in Scotland and in the United Kingdom. So we were absolutely critical, and we continue to be critical. Most of those present day challenges that I was describing, most of our professional associations that sit within the local government family are playing an active part in all of those. I know that we've got colleagues from Slade here today to talk about inclusive growth, for example. We all sit in drug and alcohol partnerships. So we are present currently in all of those partnership structures that are focused on today's population need. The challenges that we are facing today are affecting a significant percentage of the population, and they are affecting all classes. Will the scale of these population health issues that we're seeing today, will they match the scale of what we witnessed in the 18th and the 19th century? In the 19th century, we had a crisis because children were dying due to infectious disease. Today, significant percentages of our children are obese. Should we be viewing this as an epidemic? And if we did, how would we change our present and our future responses? Would we look to repeat the whole population approaches taken by our Victorian fathers through a 2020 Public Health Scotland Act, for example? And what would we put in that? That's for us to lead and to determine as the leaders of today, surely. And despite having much of our original powers and responsibilities having been dispersed over a plethora of bodies, we are active players in our community planning partnerships. These partnerships have the potential to knit everything back together, but our suite of solutions will have to be very different from those of our predecessors. That's not to take away from the scale of what our predecessors achieved and have left us with today, a water and sewage system that continues to serve our populations, for example. We need to remain focused on the causes of the causes as a whole system around our local populations. Ultimately, people live their lives in local places. They don't live nationally. So our leadership challenge is to behave as a place leader, not as a single agency, manager or sector. And it's to make sure that we are an active contributor to shaping the direction of travel for going forward, to view Public Health Scotland as much as a part of our family as it will be viewed as a part of the family for other parts of the public sector, and not view ourselves as being subservient to Public Health Scotland, but to be an equal voice in there, understanding the determinants of population health that we have in our control. I've recently discovered the delights of planning as a chief executive. I was quite ignorant about the planning function prior to taking up role, but the ability and the levers that as a planning authority we have to shape our place, it's quite formidable. I was really pleased to see the Scottish Government dropping into the Planning Act the requirement for health impact assessments. Amsterdam took a whole city approach to the abolition of childhood obesity. No developer in Amsterdam can go forward with a development unless they hardwired into their development how they're going to ensure that children are active. Their whole system, not just whole population, but their whole system, their whole place system, has said number one for priority for that place is the abolition of childhood obesity. And they're using every single lever, including the important lever of planning. So at a local level in Aberdeen, we've been having an interesting conversation about how we use planning and licensing. How would we start to use that in different ways when we know that the route to school for all children and families are kind of a key part of their journey, with all of that subliminal stuff that's going on, the fast foods, all the sponsorships, all the adverts that are going on. How could we as a local authority use our planning and our licensing levers in order to play an important part? So I think our journey is about rediscovering those determinants of population health, rediscovering those levers that sit in local government currently, and not being frightened to use them in very, very different ways. So I'd encourage it in particular in your local development plans to think about how you shape them to be public health plans from a spatial perspective. Make sure that your community planning LOIP is a public health, and that you as the specialist workforce within local government have as much an input into the LOIPs and into the LGPs as the narrower sort of defined specialist workforce that sometimes sits within NHS. So my view is that our future is in our hands, and I think when we look back at history and where we came from, and we see the leadership of that past, and no doubt the challenges that they had to face, they kind of rose to those challenges. The challenges, the population health challenges, are very, very different today and need different solutions, but it's upon us in this room. We are the specialists. I actually think that language is quite unhelpful. I think we are all public health officials. I think that's what we all do. And I think that some of that language is getting in the way and leading us into some quite narrow discussions. I think the key bit is understanding those determinants of people's lives. Housing, water, sewage were all important. There's a different infrastructure that's required for today's problems, and it's really important that we stay current around all of those. I hope that you find today useful in terms of thinking about how you're going to act when you go back to your system. I'm on a journey of discovery, of planning. I have to say I'm a complete convert. Its power is immense. It shapes places and people. It shapes economy. It's absolutely critical. So, of course, there's housing and water and sewage. And I, as a local authority chief, should remain interested in the water and the sewage, particularly when you think about those environmental challenges. So I think the thing is about recognising where we started off. We had really broad radar. We had a really broad responsibility for our people in place. We should just continue to behave like that, I think, and think about the determinants and how we can all use them together. So thank you for the opportunity to come and talk to you today. I hope you really get a lot out of the workshops in particular, and really start to think about how you're going to influence your own place from a public health perspective, and think about the powers that you had. So thank you for the opportunity to talk today.